The topic is physicians. We have with us three extraordinary individuals we're going to do the intros briefly, but I urge you to look at their full CVs. They are each physicians and executives with coming at this circumstance of looking at the alternatives, looking at what works, looking at this day-by-day changing landscape of provider options and models. So we're going to get a detailed discussion of each of their specializations, some cross-pollination, and then some questions from all of you. So let me begin. To my left is Bob Lonegro. He is the Chief Medical Officer of Celticare Health Plan and the Chief Medical Officer of CaseNet. Dr. Peter Angood, Chief Executive Officer of the American College of Physician Executives and former Vice President, Chief Safety Officer of the Joint Commission. And then Dr. Tom Lee is the Chief Executive Officer of One Medical Group. So I'm going to start with Bob and just ask these guys to quickly encapsulate their piece of this puzzle. Bob, what's your standing here?
I couldn't help but notice that the tie memo went out. I've got a bow tie, no tie, and a necktie. I'm not sure how. I've never been with two other docs, and we've all had different neckwear. Very interesting.
You're out of sync, though. You're
Yeah.
supposed to be shorter is better, right?
Yes. Thank you. So I'm an internal medicine doc and have experience in practice both on the West Coast and the East Coast. Migrated to Massachusetts after training in Southern California. Got very involved in the managed care market in Massachusetts and actually collaborated with a number of other docs and developed a very large independent practice organization south of Boston to try to compete against the collaboration and consolidation that was happening as we saw Partners Healthcare be created and Care Group be created and the Leahy Clinic, everybody buying up physicians and hospitals trying to consolidate. So here we were, a bunch of docs who didn't want to consolidate. So what did we do? Well, we consolidated, but that's a different story. And we practiced full risk Medicare. We had inpatient, outpatient, pharmacy, everything. We had full risk Medicare back in the mid to late 90s. Of course, we all know what happened with capitation back then. It got pushed away. We had this backlash. And back then, we didn't have the computer systems we have today. I got ultimately involved in commercial health care with Tufts Health Plan in Boston, one of the top-ranked U.S. News and World Report NCQA plans in the country, and spent a good number of years there. And then ultimately, in 2009, when Centene Corporation decided it was time to make a foray into Massachusetts, into the exchange marketplace, because as I'm sure you know, Massachusetts developed this mandate for coverage back in 2006. And I joined that organization in 2010 as the chief medical officer to try to understand how care was best delivered in an exchange space. Ultimately took over as president and CEO of the organization throughout all of 2013. I currently serve as the chief medical officer. It was by design that it was a limited engagement. And then we have a sister company, CaseNet, which is a technology company with a solution that maybe we'll talk about a little bit or maybe not, that helps aggregate data. And I'm the chief medical officer of that company as well. So I'm here bringing provider experience, health plan experience, technology experience all to the table to try to solve the world's problems, which I think we'll do by 3.
Okay. Good. Thanks, Bob. And we want to come back to Massachusetts because that really is a fascinating case study. Peter?
Sure, and it's my pleasure to be here as well. Thank you so much for spending some time with us. I spent 25 plus years in academics doing the trauma surgery, critical care route, and those disciplines are very multidisciplinary as well as systems oriented. And then as I got into mid-career, recognized that I was getting more focused on how to create change through systems development and systems change, and wound up getting more frustrated than more satisfaction. And I think that was in part not just my naivete in terms of early stage management, but more the evolution of healthcare and how it was really rapidly changing. I then had the good fortune of switching out of a clinical academic track and then got into the whole patient safety and quality arena and spent a good number of years with the Joint Commission International, the World Health Organization, National Quality Forum, doing a variety of activities related to safety, quality, measurement, et cetera. But then had the next epiphany in my career and realized that while it's stimulating and fun to help develop policy and implement policy and standards, et cetera, it really profiled for me that significant gap between that and what's still going on in the front line or the real world. And so I began to look for opportunity where I could have some impact potentially on that gap zone. So the American College of Physician Executives, where I've been the CEO now for about 2 years, for me represented that opportunity as they were moving towards bringing themselves as an organization to its next stage of development. And we have trained well over 100,000 docs over the course of time. Not everyone who takes our stuff has to become a member. We have 11,000 plus active members. We're in 45 different countries. And as we're expanding along our strategic plan, we really are interfacing more and more as a thought leadership group towards the policy side, but also very much privileged to have this platform of physician leaders and managers of all types, all disciplines, all types of systems, and how do they create the change in their local environments or within their local healthcare systems. And so the perspective that I bring for this discussion this afternoon is, again, that sort of long history of the clinical, some elevation at that policy level, but more what are our members around the world seeing, feeling, and hearing as it relates to what physicians need to be doing in creating positive change for healthcare.
Right. Good. And how many members here?
Currently active 11,000 plus, 45 countries.
Big piece of the pie. Tom?
Great, thanks for having me. Back to Bob's point, I don't think there's a better visual representation of practice variation among physicians than up here on stage. But anyway, I think I represent a little bit of the San Francisco, maybe, ethos to healthcare. Short stories, I'm originally trained as an internist. Had a vision for practicing traditional old school primary care medicine in Seattle and Boston. But in my training, it was pretty apparent that the system was kind of producing physicians that were not able to work in a system that fostered great primary care and great patient care in a much more traditional sense, where providers are caring for patients in a collaborative, thoughtful sense. And for me, it was a big question mark as to why the system is so dysfunctional. We had great providers and great people trying to care for patients, and an overwhelming amount of finance kind of dedicated to healthcare, but why did the outputs look so mediocre? And so it really began a journey for me. I ended up going to San Francisco to better understand the world of entrepreneurship and look at healthcare with that lens. Participated in the early team at Hippocrates, where we built up the product line and really kind of looked at innovation through a mobile device as to how it could help providers in practice. And ultimately set to create One Medical, which was the original inspiration for me to kind of re-examine primary care. And briefly, for those who may not be familiar, One Medical is a completely redesigned practice model. We use technology to kind of innovate the practice operations within the organization to allow primary care providers to spend more time with patients. And we use technology to help foster better engagement and communication with those patients. So the net outcome is, higher quality care and service at lower cost through reduced overhead and, better service level that we're able to offer. And then we're focused on building a scalable model for primary care nationally. So we're in 6 markets, including in the DC area today.
Great. Okay. So I want to get to the rubber meets the road, the physicians here, and talk specifically about that. I have a relatively large family, a 94-year-old mother. I have a wide array of specialists who keep me patched together. And the common denominator I find when I speak to a lot of these guys is, what do you want to do with the rest of your life? And the answer is retire. A lot of, anecdotal, but I think other people probably hear that. What's going through the mind of a physician right now with all of this? I want to start with Tom. You're dealing with them day to day on that, and then work through this. Take me through that. What are they thinking?
Yeah, we're definitely on the front lines in the primary care practice model, both within our practice, but also in physicians who are looking to join our practice. So we see this, across multiple markets. And what's very clear is, doctors are fairly concerned about the healthcare environment. There's a lot of movement in place, and unless you're part of a larger institution, I think the clear trend is obviously which large institution do you want to join. I think there's a lot of just question marks and fear and concern, and I think it's fairly warranted given how providers have been poorly consolidated in practice, particularly outpatient practice, and where those forces are going, obviously due to the Reform Act and some other consolidating factors in the environment. So I think the concept of, let's call it, this traditional notion of individual patient care, individual provider practices, I think is a vision that's fading away from most providers, unfortunately.
And are they still clinging to that notion when they come into practice, or are they getting trained to view the world differently?
Well, it depends. Obviously, physicians who've been in practice, who've had a little bit more context, are holding on either violently or politely to the old notion. Young physicians, I think, are reconciled to the realities of practice today. I think at the heart of it, if you really kind of probe the soul of most physicians, they want to practice individual practice model-based care away from, let's call it, large organizations and perhaps a bureaucracy. There is that perception, probably founded, that it doesn't really foster personalized care.